presentation will focus on simplified procedure. I know, Giulio, that you are very, very much into the minimal invasive procedure, but I would love to pinpoint the term simplify during my presentation, since we've been working as a group for about 15 years around this concept. So let's start with the, let's say, the historical perspective. And the historical perspective is that when we approach a surgical case in order to go through a regenerative procedure, we are always concerned about the fact that we need to maintain the papilla. Maintaining the papilla, meaning that when you are raising a flap, let's go for this mini video, when you are raising the flap, you are concerned about the fact that all the entire bulk of the interdental soft tissue is moved from the buccal aspect to the palatal one, or vice versa, depending on the extension of the lesion. But at the end of the day, we want actually to have some tissue to replace back to its original position in order to ensure primary closure and providing ideal condition for wound stability. But I must tell you that even though, I mean, this is a very, very well recognized and validated approach, almost 15 years ago, we wanted to a little bit shift the paradigm. And shifting the paradigm means also not only to be minimal invasive, but particularly to concentrate on the simplified procedure to achieve and to combine better clinical outcome and respect of the biological principle of wound stability and regeneration. Why being simplified? I mean, because of course we have tackled the issue in this particular paper that we published 2 years ago, and this simplifying the procedure have some advantages for both patient and operator that may synthesize by saying that we have enhanced condition for wound healing. As you will see, we may reduce chairside time and reduce also treatment cost. But obviously, we have also some advantages for the patient, because as you will see during the presentation, we may reduce pain and discomfort. And of course, we also may have a less impact on the pre-existing aesthetic of the patient. So what we did, and we published it first in 2007 in this small Italian journal, is try to go through what we call a single flap approach. So the idea here is that instead of going through a papilla preservation technique, the best way to preserve the papilla is to ensure its integrity. So we published this case where we show that we may elevate the flap, providing better condition for root debridement and defect degranulation. We may also graft entirely the intrabony component of the lesion and protecting the graft by means of resorbable membrane, as you will see here, and replacing the flap back that was intentionally done just by the buccal aspect, ensuring condition for primary intention closure and wound stability. And as you can see here, that we may get this condition, this healing condition at 1 year with a clinical attachment level gain of about 5 millimeters combined with pocket closure and remineralization of the defect that can be maintained over time. Here you see the 12-year results. So again, the single flap approach is based on the fact that when we are, of course, diagnosing the defect, and provided that the defect can be tackled on one side, that would happen 8-9 times out of 10, we have to take the opportunity to respect the entire volume of the interdental tissue. So the concept is that we want to elevate the flap, which is related to the extension of the lesion. So if the lesion extends predominantly on the buccal aspect, which is usually the case, as in this particular case, we go through an intrasulcular incision, and when we came to the defect, we are going through a bud joint incision, as you can see here, leaving the entire volume of the papilla. Then, of course, you may extend the incision line just to ensure a flap elevation without excessive tension. Now you see that the flap is elevated just on the buccal side. You see that we may approach the lesion to provide better degranulation, best degranulation, and ideal root debridement. We are degranulating the defect by means of this Hirschfeld file, as you can see here. And mainly, the elimination of the dental biofilm on the exposed root comes from a mechanical instrumentation, usually by ultrasound. So this is the idea. You see that now we are ready to apply the regenerative technology. In this particular case, we use the enamel matrix derivative that may promote, as you will see here, a complete remineralization of the intraosseous component without using any additional graft biomaterial. So this is the principle. The principle is try with the flap elevation to provide ideal condition for wound stability that may optimize the regenerative outcome of whatever technology we want to use. Let me give you another example. Again, this is a huge lesion in the central incisor. You see that by elevating just the buccal flap, we may provide good condition for root debridement. Here you see an enamel projection that has been eliminated by means of a diamond, a fine diamond bar. And here again, you see how clean is the root surface and how smooth is the elimination also of the granulation tissue in the intrabony component. Then, of course, the ideal regenerative procedure in this particular case was the combination of enamel matrix derivative with a xenograft. This is a bios particles. And we use what we call the sandwich technique. In other words, a first layer of enamel matrix derivative, then a combination of the graft biomaterial combined with EMD, and on top of that, in order to condition the graft biomaterial and also the supracrestal soft tissue, a second layer of EMD. And you see, we replace the flap back by means of internal matrix suture. There is no time to go through this procedure, but you see that the four major characteristics of this approach. Number one, it's an envelope flap without any releasing incision that has a limited mesiodistal extension. Number two, the interproximal supracrestal tissue is left intact. You can see the papilla that has been left in place, just cut in the middle in order to provide good replacement of the buccal flap to its original position. Number three, the elevation of the buccal full thickness flap, depending on the extension. You will see that we can also go through a palatal approach. And number four, everything needs to be done with an appropriate access for root debridement and defect degranulation, as I said. Here you see the condition after 14 days. You see the fantastic early wound stability. You can hardly see the incision line. You see the sign of the suture. And if this is the early wound stability, which we have just to provide, condition for tissue maturation with the proper supportive therapy. And this is the result. At 6 months, you see the pocket closure, 3 millimeter of residual probing depth, associated with 6 millimeter of clinical attachment gain. This will give us the possibility also to move orthodontically the teeth to provide better aesthetic to the patient. You see the long-term stability following the orthodontic treatment. So starting from 2007, when we published, we have started to gather a number of clinically relevant information for the practice, and at the same time we wanted to increase the credibility of this technique by providing an increasing amount of and robustness of the evidence. So here you see what we end up with. We started with case series, then we went through evaluation of the efficacy through randomized controlled trials, up to what we consider a summa, a synthesis, as you will see here, since we published, and I need to thank Christian Nase for this, for the fact that he has always believed in this project. We have recently published this textbook on simplified regenerative procedure, particularly to deal with deep intraosseous lesion. And since we started in 2007 introducing in the literature the single flap approach, the idea was considered valid. And you see that basically along the way in 2008, 2009, up to 2012, there was an improvement in the way other talented clinicians approached the same type of biological and clinical principle. Keck in 2008 introduced the coronally advanced single flap approach in order to move coronally, slightly coronally, and not to replace back the flap at its original position. Then in 2009, Sandro Cortellini modified a little bit this principle, and he called modified MIST, which is a single flap of limited mesiodistal extension. And finally, Giovanni Zucchelli also combined the use of a connective tissue graft with this surgical approach. But I mean, you can see that all these type of variants deal with a simplified procedure that may also result in a benefit from a clinical viewpoint, as you will see. What is the difference? The difference is nothing in terms of from a clinical and surgical viewpoint. Here is a very nice case that was given to me by Mario Rocuzio. He approached this lesion on this central incisor by the Takei papilla preservation technique. And here you see in comparison a single case of single flap approach that we have published. And you see that the similarity between the two lesions and these two central incisors with a 1-2 wall component mainly. And the only difference between the two approaches is that on one side we have left the papilla intact, whereas on the other side, Mario has elevated the papilla included in the buccal flap. Of course, if we are dealing with a lesion that mainly extends on the palatal aspect, particularly if this lesion is located in an aesthetic sensitive area, and we detect the extension of the lesion by matching the information coming from the two radiographs and the bone sounding, the best way to do, as you will see in this case, is to approach the lesion with the palatal single flap approach. And again, I'm pleased to show you the comparison between this lesion that was tackled with me just by elevating a palatal flap with this lesion that was tackled by another talented clinician, Dr. Roberto Abundo from Italy, from Turin. And again, you can clearly see that the only difference between these two approaches is that on one case, the papilla was elevated by means of a minimal invasive procedure and a simplified papilla preservation technique, whereas in the case that I've dealt with, I left the complete integrity of the papilla. But the result in terms of access, surgical access to the lesion and to the exposed and contaminated root surface is exactly the same. Here you see the results following tissue maturation, the remineralization of the lesion, but of course, just not by moving nothing from the buccal aspect, you can clearly see that by comparing the preoperative view and the clinical attachment loss and the probing depth at the beginning of the treatment by what we experienced after 1 year of tissue maturation phase, you see that we have a 7 millimeter clinical attachment gain associated with pocket closure, no periodontal inflammation, meaning no bleeding on probing. But what is more striking here is that everything was done by leaving the gingival profile completely intact. So it was unaltered, starting from the pre-op view to the 1-year follow-up. But why I'm insisting on the fact that we need to leave the papilla intact? Because basically you will see that by leaving the bulk of the interproximal tissue intact, we may amplify the biological potential of the wound lesion. What I'm saying is that when we are replacing the flap back and we suture the flap back, what we usually observe after 2 weeks of healing is that the healing phase is accelerated, is much faster than what we observe, as you can see here, when we elevate a double flap. And why is that? The idea is that if you take into consideration the blood supply to the interdental papilla, you have to realize that basically there's a rich vascular anastomosis crossing the interproximal area, going from the buccal to the oral aspect and vice versa. And when we cut the incision with the butt joint incision at the base of the papilla, we are interrupting just the buccal blood supply from the buccal aspect, whereas we may take advantage on the fact that the vascular anastomosis is bringing nourishment to the incision line and to the buccal aspect from the oral side. And that is the idea, and this is, to me, the hypothesis why we are experiencing an early wound stability leading to a primary closure and the maintenance of the primary closure after the first 2 weeks. There's also an explanation coming from these experimental studies done in animals. As you will see here, basically this Japanese group has compared the wound tissue, the wound stability, when they elevated a double flap on the control side with wound stability on the early phase when they elevated just one single flap. And to cut a long story short, you see basically that the day one, the experimental side showed a smaller infiltrated area with respect to the control side, the double flap side. And at day 3, whereas in the control side, there is a persistence of the blood clot almost disappeared on the experimental side. And finally, at day 5, you see that the experimental side showed a fibroblast-rich granulation tissues, whereas in the double flap side, the granulation tissue was still infiltrated with a large number of mononuclear cells, showing that by elevating just one flap, we may accelerate the early wound healing phase. And let me give you some example. Here you see a huge intrabony defect on the mesial aspect of this premolar that has been treated just with the blood clot protection and the single flap approach. You see at 2 weeks the wound stability. Please note that you can hardly see the incision line. And if this is the aspect, the clinical aspect, after 2 weeks, you have to wait a tissue maturation phase to diagnose a complete pocket closure and the remineralization of the defect. Or another example, again, mainly a one-wall defect. Again, we just provide blood clot protection by means of replace the flap back on a single flap approach. You see at 2 weeks the wound stability. You can hardly see the incision line and the tissue maturation phase with a complete remineralization of this challenging lesion. So the potential is high, and the potential we see as something to do with the wound healing phase, particularly in the early phase, but also translate into a clinical principle that may give us the possibility to enhance the inherent potential to regenerate for also even for these challenging defects. And finally, just to conclude, let me give you 2 examples. One comes from this a randomized controlled trial published in 2012, where we have compared 14 defects in 14 patients with a single flap approach and 14 defects in 14 patients with a double flap approach, meaning the papilla preservation technique. And in this particular study, we just tackled the predominant 3-wall component defect, and we did not use any regenerative device due to the favorable morphology of the lesion. And to cut a long story short, I don't want to show many numbers, you see that with the double flap approach, we were able to gain 3.4 millimeter, whereas with the single flap approach, without using any regenerative device, we end up with 4.5 millimeters. So in other words, 1 millimeter more clinical attachment level gain. In this second study, we did exactly the same thing. So we compared randomly 15 defects in 15 patients treated by single flap approach with 13 defects in 13 patients with the double flap approach. But in this time, since we treated predominantly 2-wall component, we use a regenerative technology, which is based on the combination of beta-tricalcium phosphate and recombinant PDGF. And again, we were able to observe that with the double flap, the clinical attachment gain was 3.2 millimeter, that increased to 4 millimeter with the single flap approach. So Giulio, the other thing is that since we have simplified, we have also measured the discomfort and the pain, the post-surgery pain reported by the patient. And we have observed that basically with the double flap approach, we have a substantially higher level of pain postoperatively up to the first 7 days with respect to the single flap approach. So to conclude, Giulio, and gives the audience a take-home message, we may possibly say with the surgical approach based on a single flap elevation, we may enhance the condition for early wound healing. And second, whenever indicated, a single flap approach seems to lead to better reconstructive outcome compared to a conservative double flap design. And finally, let me thank all these contributors, including our chairman, Giulio Rasparini, that he was part of the team that put all this information together. So to conclude, let me just leave you with the Louis Bergson sentence saying that man should be as eager to simplify his life as he is to complicate it. Thank you very much for your attention.
Thank you very much.